All right, welcome back to another episode here at Whiteboard Medicine. We're going to be continuing our Vasopressor and Inotrope series, talking today about a vasopressor and suppose inotrope too, that is not really used anymore, and that is dopamine. So this is going to be a quicker episode because we don't really use it, and you probably shouldn't be using it very often, but you might still see it. We certainly still talk about it, so it's important to know something about it. In this episode, we're going to be talking about the mechanism of action of dopamine, including its renal versus vasoconstriction versus inotropic effects. We're going to talk about dosing and pharmacokinetics, indications-ish, although there's not a lot of firm indications anymore, contraindications, adverse effects. We'll dive into its hemodynamic profile, some of the studies and evidence behind it, general clinical pearls, and then we'll actually go through some practice questions as well. For those of you new to the channel Whiteboard Medicine, all of these study guides as well as more practice questions are available on our Patreon page. And then we have YouTube channel as well as a podcast that you can check out our content in. As always, none of these episodes are intended to be acted upon as medical advice. Please stick around to the end of the episode for a full disclaimer. We appreciate y'all. Let's dive into dopamine. So starting with mechanism of action, how does dopamine work? Well, dopamine is a dose-dependent adrenergic and dopaminergic agonist. Lots of big words here. So dose dependent, that one's obvious. Different doses cause different things to happen. We'll talk about that. Adrenergic. This is something we've talked about in previous episodes on vasopressors. And adrenergic means catecholamine based. The mechanism of action uses catecholamine receptors, right? These are things like norepinephrine, epinephrine, phenylephrine, and now dopamine as well. And then dopaminergic, it acts on dopamine receptors as well. An agonist means it stimulates said receptors. So it is a dose-dependent adrenergic and dopaminergic agonist. So going into its mechanism of action a little bit more, there's some dose-dependent nature to this, right? We kind of talked about that a little bit. And these doses are in micrograms per kilogram per minute. In 0.5 to 2 micrograms per kilogram per minute, tends to act on dopaminergic receptors, D1 and D2. These are primarily in the kidneys. And it causes some renal-based vasodilation and theoretically increased urine output. You know, back in the day, there was this idea that dopamine is renal protective. You can use it for kind of renally dosed dopamine to protect the kidneys or improve renal function, but this isn't really supported by evidence any longer. So this renal dosed dopamine certainly isn't used, or I guess we should rephrase. There's no evidence or guidelines to recommend its use in this fashion. All right, so that's 0.5 to 2 micrograms per kilogram per minute. A little bit above that is 2 to 10 micrograms per kilogram per minute. And this is where it starts to act more on beta-1 receptors. As we've talked about in previous episodes, beta-1 receptors act on the heart, right? So the heart has beta-1 receptors, whereas alpha-1 receptors act on the blood vessels, which we'll get into. So at 2 to 10 micrograms per kilogram per minute, it primarily affects beta-1 receptors. It still has some dopamine D1 and D2 receptor effects. But the beta-1 receptors being in the heart do increase heart rate and increase contractility, which then increase cardiac output. Okay, and that is true, right? At these 2 to 10 micrograms per kilogram per minute doses, it affects beta-1 receptors more than the dopaminergic D1 and D2 receptors. And these beta-1 receptors in the heart increase heart rate, increase contractility, increase cardiac output. As we continue going up on doses to more than 10 micrograms per kilogram per minute, you start to get more alpha-1 receptor effects over beta-1. You no longer are getting those dopamine receptor effects. So more than 10 micrograms per kilogram per minute of dopamine, you get primarily alpha-1 effects with a minority or a lower amount of beta-1 effects. So this is when alpha-1 on the blood vessels leads to vasoconstriction that increases your systemic vascular resistance, which then increases your blood pressure, your MAP, through vasoconstriction. It still has a little bit of the cardiac beta-1 effects, increasing heart rate, contractility, and cardiac output, but it primarily increases your blood pressure at these higher doses. And this will be important when we talk about indications, because there's going to be some dose-dependent indications here as well. So dosing and pharmacokinetics. A typical dosing range, although this is more theoretical. People use all sorts of different doses, but is 2 to 20 micrograms per kilogram per minute. We talked about how that 0.5 to 2 was the old school kind of renal dosing that works on dopamine receptors in the kidneys. That is no longer a thing. So 2 to 20 micrograms per kilogram per minute, with the first 2 to 10 primarily being beta-1 receptor effects, and then greater than 10 being primarily alpha-1, at least more than beta-1 receptor effects. Onset is 5 minutes, half-life's 2 minutes, so it's fast on, fast off. Now, fast on does not mean instantaneous, right? It takes about 5 minutes to kick in. So if you were to start something like dopamine, you have to wait a little bit before we see its full effect. Just like norepinephrine is about 2 minutes. If you start norepinephrine and you give it 10 seconds and then you start increasing it and increasing it, you won't really see what that dose did, and you'll probably end up causing some hypertension because you probably up-titrated doses too quick. So onset of action for dopamine is 5 minutes, half-life's 2 minutes. It is metabolized hepatically as well as renally, so in the liver and kidneys through the MAO and COMT mechanism. So if you have significant liver or kidney dysfunction, this can lead to longer half-lives because you won't be able to metabolize it as fast, and it's excreted in the urine. But the metabolites are excreted in the urine, right? It was already metabolized to its inactive metabolites that are then peed out. Duration is short, duration of action, so you need a continuous infusion. This is a continuous IV infusion of dopamine. You're not bolusing it or, giving it PRN. It's continuous infusion. You usually titrate it based on your hemodynamic goals, often guided by cardiac output, blood pressure, perfusion indices if you're going to use it, which is a big if, which we'll talk more about. So indications. In the ICU, our humble opinion, which is just our opinion, we pretty much never use dopamine. I can't think of the last time I used it in the clinical arena. There's one small exception where, in our humble opinion, it's still reasonable, and that's the bradycardic patient at those low doses, those 2 to 10 microgram per kilogram per minute doses. Dopamine is reasonable to use because at this dose, it's primarily beta-1 effects, which will increase your heart rate. Now, epinephrine is just as good, so we tend to use epinephrine, but dopamine, it's reasonable to use for bradycardia with hypotension. Some people still use it in cardiogenic shock, right, at those 2 to 10 microgram per kilogram per minute doses, primarily affecting beta-1 receptors, although we don't tend to do that. Historically, it was used in septic shock, but this is not really done anymore. Evidence would suggest that this is a worse option than norepinephrine, so you should just use norepinephrine, not dopamine in septic shock. And then symptomatic hypotension, this isn't really a thing anymore either. So this is not commonly used, with the one caveat being, and although we don't do it because we would just use epinephrine, that you could consider using it for bradycardia at those lower doses. Contraindications and cautions: you should be careful in patients with pheochromocytoma because the alpha-1 effects. Allergy to sulfites. Some formulations of dopamine have sulfites in them. And then dopamine is really bad for causing tachyarrhythmias, so you got to be really careful with that. It can cause ischemia of the mesenteric digits, just like many vasopressors, especially if a patient has severe hypovolemia. It can really then lead to worsening ischemia, so make sure your volume replete if you were to use this for some reason. Adverse effects, as we talked about, tachycardia, given the beta-1 stimulation, and arrhythmias, particularly ventricular arrhythmias, are a big thing. Arrhythmias are one of the reasons that we choose norepinephrine over dopamine in many of these cases. It can cause myocardial ischemia, which any drug that is going to have beta-1 receptor action that then increases contractility, it can have some worsening myocardial ischemia because you're asking that heart muscle to squeeze harder, and when it squeezes harder, it uses up more oxygen. So that's not particular to dopamine. If dopamine is going through a peripheral IV and it extravasates, it gets out of the IV into the subcutaneous tissue, you can get extravasation injury through its alpha-1 mediated vasoconstriction, common of many vasopressors, which is why most of the times we're putting these through central lines, although there is some blossoming evidence on the safety of peripheral vasopressors, particularly norepinephrine. That is in a different episode, though. Nausea and headache. Dopamine can cause nausea and headache through CMS stimulatory effects. Reduced GI perfusion. It vasoconstricts the splanchnic circulation, the circulation around the bowels. That can cause reduced GI perfusion, which can lead to mesenteric ischemia. Again, many vasopressors, norepinephrine and vasopressin, do this too, although dopamine is definitely a culprit. If you get extravasation injury, you treat that with phentolamine. Just a little shout out to that, although we're not going to go too much more into that. Hemodynamic profile. What are the actual hemodynamic effects of dopamine? Remember, this is dose dependent. That's the whole story here with dopamine, dose dependent. So at higher doses, that greater than 10 micrograms per kilogram per minute, it primarily has alpha-1 effects that increase SVR, systemic vascular resistance, and increase the MAP, the mean arterial pressure. At those medium doses, 2 to 10 micrograms per kilogram per minute, it primarily has beta-1 effects, which are going to increase heart rate and increase contractility. At those low doses that we don't recommend anymore, 0.5 to 2 micrograms per kilogram per minute, there's that theoretical increase in renal perfusion, but that is not a real thing. It's not clinically supportive anymore. So hemodynamically, increase SVR and increase MAP at higher doses, increase heart rate and contractility at lower doses. The studies that have helped inform our use of dopamine, one is the SOAP2 trial in the New England Journal of Medicine in 2010 that compared dopamine versus norepinephrine, and the dopamine group had more arrhythmias, and there was no mortality benefit with dopamine. So norepinephrine was preferred over dopamine in most shock states because there's less arrhythmias. The renally dosed dopamine, there's a meta-analysis in the 2000s that showed no benefit of low-dose dopamine in preventing acute kidney injury. That's why it's not recommended anymore. There's a dopamine versus epinephrine in neonatal shock trial published in the New England Journal of Medicine in 2011. Dopamine was associated with lower mortality compared to epinephrine in septic shock. But this is specific to pediatrics and not generalizable to adults. We don't take care of pediatric patients, so we don't know all the details of that, so we're going to cross it out, and you'll have to do more research on that yourself. When we get to clinical pearls on dopamine, dopamine is not favored to be used in ICU practice. It is more arrhythmogenic. It can cause ischemia. It is not recommended in septic shock. You could consider dopamine at lower doses, 2 to 10 micrograms per kilogram per minute, in symptomatic bradycardia with low MAPs, just as a bridge to whatever you're going to do to fix that heart rate. That's not unreasonable, although we usually use epinephrine instead. If you are using dopamine, watch out for peripheral ischemia, and central access is key, especially at moderate to high doses, because extravasation can be limb-threatening. So in summary, dopamine is an endogenous catecholamine. It primarily works on catecholamine receptors, beta-1 at 2 to 10 micrograms per kilogram per minute, and alpha-1 at doses higher than 10 micrograms per kilogram per minute. The onset of action is about 5 minutes, so you need to give it a couple minutes before you see its effect. Typical dose is 2 to 20 micrograms per kilogram per minute. The arrhythmia risk is very high, and this whole idea that it helps renal perfusion is not clinically borne out in trials. Some practice questions, 3 of them, starting with beginner. We'll do the practice questions as we always do. I'll read the question and the answers. I'll say quickly, pause if you need more time, and then I'll go into the actual answer. So if you need more time, make sure to pause it because we'll go right into the answer. Beginner question level number 1. Beginner level question number 1. That makes more sense. Which of the following best describes the receptor effects of dopamine at doses between 2 and 10 micrograms per kilogram per minute? A, pure alpha-1 stimulation. B, pure beta-2 stimulation. C, predominantly beta-1 stimulation. Or D, predominantly dopaminergic stimulation. Pause here if you need more time. The answer is C, predominantly beta-1 stimulation. So at this range, dopamine increases inotropy and heart rate via beta-1. Right? Pure alpha-1 stimulation tends to be greater than 10 micrograms per kilogram per minute. It does not cause beta-2 stimulation, and then predominantly dopaminergic stimulation is that 0.5 to 2 micrograms per kilogram per minute, although there's no reason to use it at these doses anymore because it is not shown to be renal protective. All right, intermediate level question. Which of the following is a major reason dopamine is no longer preferred as first-line vasopressor in septic shock? A, it causes hyperkalemia. B, it lacks any beta-adrenergic activity. C, it has a higher risk of arrhythmias. And D, it improves renal perfusion too strongly. All right, pause here if you need more time. The answer is C. It has higher risk of arrhythmias. Remember that SOAP2 trial published in the New England Journal of Medicine showed that there was more arrhythmias and adverse effects with dopamine as compared to norepinephrine, which is why we use norepinephrine for these patients. It does not cause hyperkalemia. It does have beta adrenergic activity, right? Those doses between 2 and 10 micrograms per kilogram per minute are primarily beta 1 effects. And then it improves renal perfusion too strongly is just a ridiculous answer. But even the whole thought that dopamine can improve renal perfusion is no longer borne out as true. Last question, the advanced level. A patient in cardiogenic shock has a MAP of 68 millimeters of mercury and a heart rate of 48 beats per minute. You are considering dopamine versus norepinephrine. What factor might favor dopamine in this case? A, risk of renal injury. B, need for alpha-1 mediated vasoconstriction. C, coexisting bradycardia, or D, risk of tachyarrhythmias. Pause here if you need more time. The answer is C, coexisting bradycardia. So the one time in which we say you could consider dopamine, although we do not do this in our practice, is bradycardia. Dopamine may increase heart rate in patients with bradycardia, making it temporarily helpful, potentially, as a chronotrope or a drug to increase heart rate. None of the other answers is useful, and even this for us, we do not do this, but we at least wanted to put something in there for how you could potentially consider using dopamine. That's all we have for you today. If you want access to this study guide or additional practice questions, check out our Patreon page, check out our YouTube or podcasting platforms. We appreciate you all. Stay well, keep learning, and we hope to see you next time. Hey everybody, and welcome to Whiteboard Medicine. We appreciate you checking out the video. Here at Whiteboard Medicine, our goal is to create medical education content for all types of interested learners. That includes videos, practice questions, study resources, and much more. We would love for you to join our community by subscribing, hit that bell button. We're also working to build a high-yield Patreon page. It's going to be full of practice questions, video outlines, notes, commercial-free content, and much more.
None of these videos are intended to be acted upon as medical advice. Please pause the video here and read this disclaimer in its entirety before moving on.